Hi, welcome to the download. What time is it? Is it 10 o'clock? We have about half the people we were expecting. I hope you don't mind if we wait about 3 more minutes. Thank you for coming. Yeah, give us 3 more minutes. Usually sometimes we have music. Today we didn't have music, music while we were waiting. I hope you don't mind. Good morning. Good morning. I know usually this is later in the day. I was like kind of caught off base, to be honest, but that's cool. That's cool. It's a good way to start the day. We're in very good hands today with our Chief Privacy and Policy Officer, Shreya Patel, giving us a policy update. We have 30 people. We're waiting for about 30 more, but we're only going to wait like 3 more minutes. Is that okay? Rachel, is Shreya here? Shreya's here. Great. I see you.
Hey, Joanne. Yep, I'm here.
Are you you're going to be sharing your slides, or do we get to see you?
Yep, I'm going to be sharing my slides. I'm off camera today, if that's okay.
Okay. I mean, it's better when you're on camera, but I understand. It's a Wednesday. We have to be on camera on Tuesdays and Thursdays, but it's not mandatory Mondays, Wednesdays, or Fridays. I don't know how all you guys do it. Maybe you're back in person. I don't know. All right, 1 more minute here, and then I think we will get started. The number's holding steady. Okay, Rachel, let's do it. You are here at MiHIN's The Download, a monthly webinar to talk about like the big topics between technology and healthcare and data and privacy and requirements. My name is Joanne Jarvie. I am the Senior Director of Outreach and Market Communications. I am being supported by my business partner, Rachel Kelly. My role here is to make sure that all of our stakeholders know what we're doing, how they can reach us. I am supposed to be your conduit to our support. So please use me. Please feel free always to reach out to me. Ask me to get you in touch with other people. I bother people all day long, and it is my pleasure. Next slide, please. MiHIN. Who's MiHIN? MiHIN is the nonprofit organization that has been designated by our state to connect different health organizations, different care providers that make up the healthcare ecosystem, connect those disparate organizations technically and legally to share information to make humans better. To make them healthier, to make them well, to make the process of medicine and healthcare more seamless and less expensive and more impactful. But I should say also that I am on the human infrastructure side of our business. Health information takes human infrastructure and technological infrastructure. And they need to rely on each other to make sure that we have a balance. From my perspective, technology is a tool that is supposed to support human beings. It is supposed to allow us to communicate and connect and collaborate. It is in service of us. We shall not be in service of it. So let's keep that in mind as we move forward. Does anybody have a question about MiHIN? Do you know who we are? Do you have any, any pointed questions at this point? Okay, great. Thank you for coming. Thank you for being with us. Thank you for working with us. Today's agenda, that was my welcome, Joanne Jarvie, but you're here for the star of the show, Shreya Patel, Chief Privacy and Policy Officer, for her public policy updates. Just a little background on Shreya. Shreya always makes us look good. We are blessed to have her working really hard on our team. She routinely examines the effect of national and state initiatives on interoperability, participates in national dialogues around trusted exchange framework and common agreement, TEFCA, the final interoperability rules from the ONC and Centers for Medicaid and Medicare Services. She is always out in front, always looking forward, making sure that we can support our stakeholders as requirements come down through government. She has a Bachelor of Arts degree from the University of Michigan and her Juris Doctor from Michigan State University College of Law. Shreya, please take it over. Also, you guys, I am in the interrupting, I'm in the interrupting camp, but I don't know, Shreya, you like to run a pretty tight ship. Do you want people to wait until you are finished with each of your sections to ask questions? We can be manning the chat for you. How do you want to work it?
I'm okay with taking questions as they come in. I left some time at the end for questions, but because I'm moving through like 3 different topics, if you want to continue a discussion on a particular slide and just want to jump in, feel free to interrupt me.
Please feel free to make this be a dialogue. If you don't understand something, you need to ask the question right now. It's burning. I get it. I'm with you. And we will have time at the end for more discussion and more questions. So thank you. Shreya, over to you.
Awesome. I'm just going to go ahead and steal the screen sharing. Let me know if you're able to see my slide deck come up in the next couple seconds here.
We got it.
Okay, awesome. Well, thanks, Joanne, so much for that super nice introduction. So as you mentioned, I'm the Chief Policy and Privacy Officer at MiHIN, and today I'm going to be giving a bit of a 2022 policy update on 3 different topics. So today we're going to be covering the 2023 inpatient and long-term care hospital prospective payment system proposed changes. Second, we're going to delve into the introduction of the streamlined modular certification and the sunset of the 2 programs that preceded it. And then we're going to end on the release of 2 TEFCA related standard operating procedures, or SOPs. So the first topic that I'm going to cover today is the 2023 Inpatient Prospective Payment System. And for those of you who are unaware of what the Inpatient Prospective Payment System, or IPPS, is, it's basically the way that CMS pays acute care hospitals for inpatient stays, with just a few exceptions in the law. And then it's also going to be the way that CMS sets base payment rates prospectively for inpatient stays based on what a patient's diagnoses are and then any services that have been performed. And then what I have on the screen is that it should also be noted that when we discuss Inpatient Prospective Payment System, or IPPS, we're oftentimes also discussing the long-term care hospital prospective payment system, which is similarly the way that a long-term care hospital would be paid under that same kind of model. And this latter one is abbreviated LTCH-PPS. So we're going to be discussing changes to both of these rules today because they were kind of released around the same time in April of this year. Though I will say that the focus might be a little bit more on inpatient, just because there was a little more content on those changes in the rule. And I will say that I'm going to do my best in this presentation not to abbreviate too much, just because we're covering 3 different areas, and the abbreviations, as you can see, get really long and out of hand. So I'll try to say out the rule as much as I can. All right, so on the last slide, I went into what the Inpatient Prospective Payment System and the Long-Term Care Hospital Prospective Payment System is, but I wanted to quickly discuss why it matters and specifically what it would mean for some of our hospital stakeholders if passed as is. So the reason that these rules are really important is that they introduced requirements for hospitals on a variety of topics this year, and also included things from attestation and reporting requirements to internal processes and standards that a hospital must implement, to soliciting feedback on new conditions of participation, all of which could affect an entity's CMS or Medicare funding. So while we definitely can't stop the passage of these rule changes, many of which are actually created to further healthcare quality and promote that more accountable care model. One thing that we absolutely can do is provide comments or feedback during their open comment period on if these changes are actually feasible in the timeline that they've proposed, or what needs to be improved upon. So today I'm going to walk through some of the 2023 changes, and then also just discuss some feedback that MiHIN is going to be submitting during the current open comment period. But as always, and as Joanne kind of mentioned, we'd love to hear from you on if you believe that CMS has hit or missed the mark on some of these proposed changes. As I go through this, please feel free to leave any feedback in the chat or verbally. You can wait till the end of the presentation or even send us an email after. The comment period is going to be open until June 17th, so we do have some wiggle room. But we'd really be happy to incorporate your thoughts in our submitted comment letter, just to alleviate any burden that your organization may have submitting separately. All right, so now to kind of move on to the meat of the presentation, we're going to be walking through just a few of the areas that the proposed changes focused on this year. So that's going to include Medicare maternal health equity at large, social determinants of health, or SDOH, health-related social needs, or HRSNs, supplemental payments for Indian Health Services, Tribal Health, and Puerto Rico hospitals, measuring healthcare quality disparities, and then I kind of have like a catch-all that says and much more, and I do have a slide on what some of those other areas are, but this is really the areas that had the most language and content dedicated to them. All right, so to start with, maternal care was really emphasized in the 2023 rule, and this makes sense because maternal care is a huge priority of the current administration, and they proposed changes under the Hospital Inpatient Quality Reporting, or IQR, to basically establish a publicly reported, public-facing hospital designation on the quality and the safety of maternity care. So this would basically entail two new measures, and one is going to be the cesarean birth, ECQM, and then the second is going to be the severe obstetric complications, ECQM. And both of these measures would need to be available for hospitals to select for reporting beginning in calendar year 2023, but it wouldn't actually impact payment determinations until 2025. And just as a refresher, for those of you who are not aware, electronic clinical quality measures, or ECQMs, are basically tools that help measure and track the quality of healthcare services that eligible hospitals provide. So measuring and tracking and kind of actually just reporting of ECQMs really help to ensure that our healthcare system is delivering effective, safe, efficient, patient-centered, equitable, and timely care. And the objective of the measures that are proposed here would be to track things like the number of cesarean or C-sections, as well as the number of adverse maternal events, including hemorrhage, embolism, severe hypertension, stroke, and opioid use, whether safe or unsafe. And then, kind of unrelated, CMS also requested information on if conditions of participation should be introduced for advancing maternal health equity, and additionally how racial, ethnic, and geographic considerations should be worked into these proposed changes. So, they definitely proposed some new measures, but much of this rule is requesting information and trying to receive feedback from stakeholders that would ultimately be affected. The next key area that the proposed changes touched on is health equity, and there was a significant overlap when it came to the discussion of health equity, social determinants of health, and health-related social needs. And so just as a reminder, health equity ensures that every individual has the opportunity to be healthy regardless of their circumstances, but it is going to be influenced and tied very closely to social determinants of health. So social determinants of health, or SDOH, are kind of these broad conditions in the places where people live, learn, work, play, that affect a wide range of conditions in the range of, I guess I should say, health and quality of life risks and outcomes. But kind of on the flip side, health-related social needs are going to be those kind of more immediate factors that impact what individuals do and can do on a more moment-to-moment basis. So I have an example that I like to use, and that one's lack of transportation, which is kind of a social determinant of health, would result in the more individual level health-related social need of if you're able to show up for an appointment or fill a prescription. So it's not necessarily like cause and effect, but it's more broad as opposed to a narrow focus. And so I know this can all get confusing, and the proposed rule definitely blurs all these lines together. But the main takeaway here is that they're really primarily concerned with how to screen for factors, how to report on factors, and really how to emphasize the importance of these factors on preventative care and on care coordination moving forward. So what CMS did here is they proposed a hospital commitment to health equity measure, and that would examine 5 key domains. So the first one would be strategic planning that prioritizes health equity. The second one would be improved data collection. The third one would be effective data analysis. The fourth one would be quality improvement efforts. And then the fifth one would be leadership engagement on fostering a culture of health equity. So it would be kind of a combination of all of these 5 factors. Also, the proposed rule also emphasizes screening for social drivers of health for patients that are 18 plus that basically agree and indicate prevalence to determine personalized patient action plans. So again, we're seeing a measure proposed, but CMS is asking questions of those entities that would ultimately be affected, the best way to be, for lack of a better term, kind of tested on these measures. And it's also going to be really interesting because we're going to start to see them emphasize areas like patient autonomy and consent to share what can be sometimes sensitive information. So, that can be a positive thing, and it can also be a barrier to care. So if your organization does have a unique perspective on this, this would be, the perfect time to submit a comment.
Shreya, how do
All right,
people
so
submit comment? Like they
So
just go to, would they go through us? Do we submit comments on behalf of our stakeholders, or do we encourage stakeholders to go to CMS directly?
It's really preference of the organization. So in the past, we have always encouraged organizations to submit comments. More feedback is always better than less feedback, particularly when it's going to impact those organizations directly. But, bandwidth is a huge concern of a lot of our stakeholders. So they might not have the time and the resources to do a deep dive into all of these rules, kind of assess how it would impact all of the areas of their organization, and then submit that comprehensive feedback. So we kind of take on that responsibility ourselves and say, as the state designated HIE, we're going to submit comments on behalf of not only us, but all of our stakeholders. But, there's no wrong way to do it. If you want, you can always submit feedback to us and we can incorporate it. You can also submit your own comments, or even a combination of the two. We love to share a comment letter beforehand because we have no problem with people even taking some of our comments directly as is and inserting them in your comment letter if you agree with it, because ultimately, CMS is going to be looking for patterns in the feedback they receive. And if a lot of entities are all saying the same thing or concerned about the same things, that might more greatly impact what they ultimately end up finalizing in their final rule.
Thanks for explaining that.
Yeah, and if anyone is interested in how to submit comments yourself, please let me know. It's kind of annoying because when a proposed rule is released on the Federal Register, you have to do it right through the CMS website. Of course, the deadline is June 17th. It's usually by a certain date, but basically it's just uploading a file on a web page. You just need to make sure that you found the right comment period. But again, more than happy to help with things like that. All right, so another area that the rule addresses is the supplemental payments for Indian Health Services, tribal hospitals, and Puerto Rico hospitals, many of which absorb the cost of uncompensated care. So CMS is proposing to discontinue the use of low-income insured days as a proxy for uncompensated care in determining the amounts of payment. So they really just want to change the way that how much these hospitals receive is calculated. They're also proposing to establish like a new supplemental payment for the hospitals that would be a little more consistent, but we did submit some feedback that I'll go into a little bit later in the presentation on the harm that this may cause to these hospitals that are already struggling to meet these costs. All right, so while most of the rules thus far live in the inpatient prospective payment system, this next slide discusses a portion on healthcare disparities that actually come from the long-term care hospital prospective payment system. And so currently, the landscape is long-term care hospitals must attempt to identify factors that they believe are causing performance gaps and healthcare disparities. And they're really already responsible for developing strategies to address them with very little guidance from CMS, or really from any federal level. So CMS in this rule proposes to use already available enrollment, claims, and assessment data to help long-term care hospitals better estimate the impacts of various social determinants of health on health care disparities. So basically to do so, they propose using something called a regression decomposition method to estimate the extent to which disparities in measure performance between patient populations can be attributed to specific clinical or non-clinical factors. So this regression decomposition could also identify and calculate the specific impact of social determinants of health and other factors on those disparities. And they really want to use those results to not only understand themselves how to narrow those gaps, but also to help long-term care hospitals themselves better address disparities within their facilities. And so they can kind of determine where to target their prioritization of certain performance areas. And just as a side note on this one, because I did have to look it up and re-look it up many times, regression decomposition analysis is by definition based on linear relationships of a dependent variable in terms of independent variables and subpopulations. And so to put that in the most simple terms, it's basically analyzing the fact that social determinants of health, or even health-related social needs, if they so choose, would have on certain health conditions and outcomes in categorized subpopulations. So it's just a different way to look at the data. And then lastly, and interestingly, CMS emphasized a new area, and that was climate change in this rule. And in more of a request for information, it seemed like CMS was really interested in the impacts of climate change on healthcare, and that includes like climate-related emergencies, how to prepare for climate impact, the emergency preparedness of an entity for a climate-related event, what an entity's business continuity or disaster relief process might be, and then any sort of measures for the effect on a community when a climate change event does occur. So that was something a little bit new, so we thought it was worth calling out. All right, so as I mentioned, we kind of focused on areas that were very prominent in the rule and in the summaries that we read. We focused on areas that were particularly new or interesting, and we focused on areas that kind of aligned with some of our emerging subject areas like social determinants of health and health equity. However, there were many changes in this rule, and I've listed a few of those areas on the slide just to kind of call it a few, but I really do encourage all organizations to go back and look in more detail if you'd be subject to any of the changes. I also created a summary that I'd be happy to share, but for this one, as opposed to kind of sending it out to the entire group, I would just prefer if people reach out to me directly just for the more detailed summary, because I did create that for more of an internal audience, so I would just have to tweak a few things. But if that is something that you're interested in, you don't want to sift through the entire rule, my email is on the last slide of this presentation, and I'd be more than happy to share it. I'm sure, you know, Joanne, Rachel, and Katie, and any of the others on the call could also route you to the right place if you need that. All right, so as I mentioned at the beginning of the presentation, MiHIN is going to be submitting comments to the inpatient and long-term prospective payment rules, and I've kind of outlined some of the areas where we have weighed in. The comment letter itself, I would be more than happy to send to everyone on the call and on the download list. This is something that we want to get out early and we want to receive more feedback on, so we have no problem sharing this. But just to kind of walk through some of the areas where we've already drafted comments. First, we ask for greater insight into how reported data will be actionable or used moving forward to truly move towards that accountable structure that's mentioned time and time again. It sounds really good in theory, but we want to know how it would actually work. Second, we ask for health information exchanges or health information networks to be specifically listed as a resource for meeting certain measures or to show evidence of meeting certain metrics, as HIEs have kind of been listed for conditions of participation in the past. And if there's any way that we can kind of utilize the relationship that you already have with us to help you meet some measure or metric, or have at least be a positive factor in that direction, we'd love it if they could call that out by name. Third, we asked for clarity on how to best match individuals into quality initiatives and just insight into how patient autonomy and privacy are to be preserved while kind of promoting the sharing of information that would be very pertinent to healthcare coordination. Fourth, we submitted comments on the burden of conditions of participation, particularly during a time where it does seem like hospital resources are already stretched very thin. And we suggested a more phased approach where we could do some of those easy wins right now, and then just include on the roadmap some of those more stringent conditions of participation for the future. Fifth, we gave feedback on the challenges of sharing information with community-based organizations, particularly when it comes to social determinants of health and health-related social needs. And that's just really due to the ambiguous privacy regulations that we've been grappling with for you know, the last decade, if not more. Sixth, we requested detailed information, but also provided feedback on what criteria might be used to meet measures for health equity that were more ambiguous. So when we see things like leadership's dedication towards health equity as a measure or as one of the domains that they would need to provide evidence on, that's very, very vague. And while that can be good, that could also be detrimental. So as much detail or guardrails as we could get from CMS, the better. Seventh, we requested that no supplemental payment be sunset without confirmation of its replacement underway. And that one's really related to the supplemental payments to the Indian Health Services, Tribal Health, and Puerto Rico hospitals. We just don't want to create a situation in which they already have the burden of uncompensated care, and then we take away a supplemental payment very quickly. And then lastly, we provided feedback on promoting incentives for providers as opposed to penalties. We definitely see the value in making public-facing reports and things like that, and how that can motivate organizations to do a little bit better. But when it comes down to the specific provider level, we find that incentives might work a little bit better. And then just, you know I said it before, but we have a draft that we're able to circulate, but the point of me really briefing on this is just to receive feedback on the impact to your particular organization. One thing that I will say is if you have any feedback for CMS in general on any of these topics, even if it doesn't relate to a specific proposed change, I do think it's worth it for us to just throw it out there through the process of public comment and rulemaking in general. They're required to respond to all the comments that they receive. So if you are looking for guidance on a particular area, this is a really good opportunity to receive it. All right, I'll just pause here for any questions on the proposed rule changes before I move on to the next subject area. But you can also take time and think about it and ask towards the end as well. The next area that I'm going to provide an update on is something called the Streamlined Modular Certification. And MiHIN recently created a brief on this, which we can also share out, but this is related to CMS's State Medicaid Director's Letter, which sunsets the Medicaid Enterprise Certification Toolkit and the Medicaid Eligibility and Enrollment Toolkit, and introduces a significantly streamlined modular certification process. So for those of you who are completely new to this area, the Medicaid Enterprise Certification Toolkit was created in 2007 and last updated in 2018 to assist states as they kind of planned, developed, tested, and implemented their Medicaid management information systems, which were then, called Medicaid Enterprise Systems. And then the second one, the Medicaid Eligibility and Enrollment Toolkit, was released in 2017 and really just served to assist states as they work to streamline and modernize their eligibility and enrollment systems. So this streamlined modular certification would basically sunset both of those aforementioned toolkits and provide an updated one to state Medicaid agencies and their technology vendors. So when it comes to why this matters, the purpose of this is really just to encourage accountability and ensure that the technology that states are investing in are actually producing positive results for their Medicaid populations. So continued reporting and metrics under this streamlined modular certification are going to try to ensure that states are going to be able to maximize their Medicaid match funding. So this update in particular is actually just going to be most applicable to state agencies and their associated technology vendors in charge of creating that advanced planning document, or APD, and operational advanced planning document, or OAPD. However, it's definitely going to impact the way in which reporting occurs moving forward to really ensure that positive health outcomes are occurring. And then kind of on the flip side, it's also going to be applicable to maybe just all healthcare stakeholders around the state who are able to work with the state Medicaid directors just to dictate what the priorities for improvement should be so that states can really measure and report against those goals. So those goals are definitely flexible and they are set by the state itself. So if you have a particular interest in seeing improvement on a specific subject area, that's a really good time to begin that dialogue or reach out to MiHIN to begin that dialogue as a technology vendor. And then lastly, or the last kind of public policy update for this presentation, I'm going to touch on a few updates to the Trusted Exchange Framework and Common Agreement. As this was the item that I discussed the last time that I presented on the download, I just wanted to give a bit of an update because we have seen some movement. All right, so what has happened since I was here last? Recently, as of last week, 2 standard operating procedures, or SOPs, were released, and the QHIN application was released as well. And these were kind of released in draft form, but it's the first time that we've seen a draft that likely will be finalized moving forward. So the first standard operating procedure that was released for comment was called the Draft QHIN Onboarding and Designation Standard Operating Procedure. And I will say that none of the information in this was particularly surprising to us, but it did provide a lot more detailed information and a kind of checklist on what entities would need to do to complete the corresponding QHIN application. So I know I covered a lot of this in the last presentation, so I'm not going to go into too much detail on it now, but just as a summary or reminder, it included things like being a U.S. entity, being able to exchange required information through query for the exchange purposes listed. It included demonstrating compliance with the legal common agreement, the QHIN technical framework, and all of the standard operating procedures and guidance that Sequoia Project has come out with. It's also included, that an entity be sending and receiving information in the millions, that they have a comprehensive governance structure for oversight on breach reporting and dispute resolution. that they have kind of like an organizational structure and a description of all the financial and personnel resources, that they be certified by a security framework like High Trust. And then they also laid out different timelines for approval, denial, how long you would have to wait to reapply, and then testing. And we are particularly interested in testing, but it looks really similar to the testing process for eHealth Exchange. So again, we didn't really see anything too surprising or anything that seems like a huge hurdle, but it was really nice to see all the information and what supporting evidence could be in a more detailed manner. The second standard operating procedure released was titled "The Types of Entities That Can Be a Participant or a Sub-Participant." And the title here is very self-explanatory. Here they just list out the entities that could connect to a QHIN that may not be able to or may not even want to meet the standards of being a QHIN itself. So as you see, it includes basically everyone in the healthcare space, but they list out a covered entity or a business associate, a government healthcare entity, a healthcare provider or its agent or contractor, a federal, state, local, or tribal agency instrumentality that basically determines whether an individual qualifies for certain government benefits. It includes public health authorities, individual access service providers. So even think of those applications that are covered under the CMS patient access rule, any entity that kind of contracts and enables connectivity. And then they even have this like last category that says, if you are a healthcare stakeholder that isn't listed, we're gonna figure out a process for you to basically be added on this comprehensive list. So that's what's covered in that one. And then lastly, and as I stated before, they released that QHIN application itself. And so this is something that ties really closely to the first standard operating procedure. And in a way, the first standard operating procedure is almost like a set of instructions for filling out the application. But this is going to be really important for organizations who are hoping to apply and really want to begin to work their way through the document with the right evidence. So we already know that they're going to be accepting applications on a rolling basis. So this is a good way to really just get started on that and see if your entity might be able to apply and meet some of the questions that are outlined there. And that's all that I have for today. I'm happy to take any questions, comments, or feedback. I haven't been keeping an eye on the chat, so I'm not sure if anything is there, but feel free to jump off of mute and ask questions if you do have any.
That was a lot, Shreya. I think you do excellent work. So I'm just going to open this up to the group here. Was this just a review for everybody? Have you all been doing your deep dives into these specific areas? Would you like to hear more? Are you planning on providing feedback? How can we support you? Does anybody want to learn more? Does anybody feel like this is not applicable to their work or to the future of their work? Are there other organizations represented here that are doing similar work that would like to jump in and offer some feedback? Do you want to go and get some time back? Is today Wednesday?
Yes.
Yeah.
Yes.
Thank you. It is. Today's Wednesday.
I would appreciate more information. Like we're going to receive these in a follow-up email, correct? The slides of the presentation today, or?
You can receive them in a follow-up email. We have all of our downloads and bits and bytes listed on our website, which for the next 2 weeks is going over a major uphaul But
Okay.
yes, absolutely. I can send a follow-up with these excellent slides in the recording for sure.
Thank you. I appreciate that. It was a lot of information. I'd like to be able to read through it, kind of read over it again. Unfortunately, then I may have more questions.
Oh, well, that's what we're here for. So let us provide you value.
Okay, well, thank you.
Thanks. Shelley, where are you from?
Michigan.
Where? But where? Where? What do you do?
Oh, Heartland, Michigan.
Nice.
Uh,
Good. Thank you for being here.
This is my one that I received kind of an email of an invite. So thank you for the invite.
Yes, come to all of them. There's so much more. You know, I'm wondering also, Shreya, I just feel like we should do policy updates at least twice a year. And you should probably have like your own page on the website. I don't know. I'm going to build out your whole brand.
Yeah, that sounds great. Would be happy to do policy updates as much as we need them. And I will also say we'll definitely send out the slides and the recording. I'm really light on slides, so we'll also send out that brief that I was talking about for the streamlined modular certification. We'll send out our comment letter with all the comprehensive information. And then we did prepare a couple TEFCA summaries as well that we can also send along. So maybe if we can just send that to all the participants of this call, Joanne, and if you want to put it on the website, I have no problem with that as well.
Yeah, we're going to put it on the website. We're going to send it out in the interface, which is the monthly newsletter. We're getting it out there. It's a lot of hard, excellent work.
And that's greatly appreciated to send kind of more of the detail behind the slides. Thank you.
Yep, for sure. And I know that this is 3 kind of dense topics this time. This one definitely is not exciting as the TEFCA presentation that we gave. So feel free to kind of absorb everything. And like I said, you know, we have about a little under a month of wiggle room on when we can provide feedback. So take your time with the information and just follow up. I'm not even sure if there might even be another download presentation in between then and when the comments are submitted. But Joanne, I'll leave that up to your discussion.
I hate when things are left up to my discretion. My discretion is related directly to what our stakeholders want. So I'll just ask Julie Lowry what she wants. Okay, guys, I think that we're here. It would end at 11. I will give you back these 15 minutes. Let me work on my for the next 15 minutes. I'll put together all those things and send them to you so you have them. And you can always look at our website, which, as I will say, over the next 2 weeks is going over a major overhaul. And all of this will also be included in our monthly newsletter. Thank you for being with MiHIN today. I really appreciate you. Write me, call me, SOS. Thanks for being here.
Thank you.
May, thank you.
Bye.
Okay, bye.